Thank you for the introduction, and thank you, Dan, for your comments. That almost sounded like an obituary. Actually, I still work at Park. I'm still working part-time there, and I'm still medical director for patient safety there. And when I started this, the transformation, or our transformation at Park with Lean, I was actually paired with the chief nursing officer in a dyad leadership role to manage the hospital practice. So that was our service line. And so we had our inpatient services. We had, along with that, some of the ancillary things like our social service department, our spiritual care department, lab, things like that. And so just a little more background. Park had been working on various types of quality improvement initiatives for some time. I started my interest in patient safety and quality with a collaborative project with IHI, which I understand some of you are familiar with, back in the late 90s. So that's the PDCA sort of cycles, rapid process improvements in short cycles. Same kind of philosophy that you hear with Lean. The difference with Lean that you'll hear about later on here is this all is gauged to tack time, gauged to time. Time is a critical part of the quality improvement activities that go on with Lean. And I'll try to make that clear to you as we go on here. One other thing, this is kind of a formal presentation. I don't like formality personally, so if you have questions along the way, interrupt me. I'd rather talk with you about your questions and concerns, not just talk at you. But we'll start with this as our framework. We want to discuss today a little bit about what Lean is. Current state and challenges, at least from the perspective, this was done up actually with U.S. healthcare largely in mind in terms of current state. Some of these things are translatable to your situation, some may not be. I acknowledge that up front. But I think we're all concerned about the safety, the quality of the care we give to patients and their experience. A lot of this is about time, your time, how much time do you have to care for patients? And then cost. Cost, at least in our situation, is an underlying problem because our patients can't afford our care any longer. And in the U.S., you may know that a lot of the employers purchase health care for their employees as a benefit. They can't afford health care anymore for their employees. So we have a conscious effort going on to try to improve value, improving the quality of the outcome for the patient, the experience of the patient, all at a lower cost. I want to try to make some examples for you about how Lean has made a difference for us. These are just a few examples. The rooming issue is that says 1 in a million. We have about 1 million primary care encounters a year at Park across our 25 or so clinics. And so early on we took on some initiatives around how to be more efficient and even just getting a patient into a room. And I'll show you some examples there. In Minnesota we have there's a collaborative going on where we actually compare care systems and clinics in their ability to care for patients with diabetes. And it's not just their A1C, it's a grand slam. It's their A1C, it's their blood pressure, smoking cessation, eye exams, and lipid management. And so I'll show you some examples of how we did to try to attack this and try to improve better quality for our patients. One of my biggest areas of focus is trying to reduce the risk of harm to patients. We all make mistakes, we're all human, we're going to make mistakes. Making those impossible to get to the patient to cause harm is what my goal is. I'll show you a case where we failed, where we took out the wrong kidney on a patient and what the implications were for that. We'll go a bit into some of the tools and some of the Lean concepts, and then hopefully I'll try to make the case for you that doctors being a part of this is critical to the success, not just in the U.S., but here in Saskatchewan as well, which is why I wanted to sign on with John. When I heard he was doing this, I thought this was incredible. And it's really why I volunteered with him to try to be part of this if I could. So a little bit about what is Lean. Some of this is going to sound like industry to you, manufacturing, but it's really a system, a production system, which all parts of the healthcare production system, we're all producing healthcare and better care for our patients, are focused continuously on eliminating waste and continuously trying to improve the work that we do and the product that we deliver to our patients. So it's a management system. Its whole purpose is to deliver value to the patient. The patient in our circumstances, the customer. Everything we do is really around trying to deliver value and service to our customer. Unlike a lot of quality improvement systems, your best ideas and your best engagement for how you improve comes from the frontline employee. And so you'll see as we go on with this, a lot of this work deals with getting people at the front line, at the direct patient care end of this, engaged in problem solving, engaged in making things better, engaged in improving their own work, and not having somebody improve the work for them or tell them what they should be doing. We talk a lot about visual control, visual signals, making things visible in the workplace. When you make things visible, it's amazing how obvious things are in terms of waste, in terms of things that aren't going well, and your ability to intervene earlier on before it causes harm. And again, the fundamental metric with lean improvement activities is time. So we can talk about current challenges like safety concerns and quality concerns. We all have time constraints. There's a fragmented delivery model that I assume that you are familiar with, just as we are here in the U.S. From my experiences with Five Hills and Sunrise in particular, I understand a little bit about some of the difficulties that you deal with trying to deliver a package of care and a continuum of care to patients. Reimbursement models may not be the same. I understand that, and I'm not going to spend a lot of time talking about that. But the cost of human capital and resource in trying to care for patients, particularly all of our time constraints, I think is common to both of us. What's near and dear to me is the cost of medical errors. This is actually a journal article some of you may be familiar with from back in 2004 that looked at healthcare costs across the entire state, all of Canada. This was back, I think, in 2009. And their finding was that preventable medical errors contribute to between 9,000 and 24,000 deaths in Canada each year. This is not unlike the IOM report you may be familiar with the Institute of Medicine back in 1999 came out and said we were killing almost 100,000 patients a year in the U.S. From this study, 1 in every 13 patients in acute care Canadian hospitals experience one or more adverse events per their definition. Of those, 37% of these are thought to be highly preventable. And of those, well, I'll get to that in a second. So the cost of this, though, it can be translatable for each individual patient who's had a preventable error. You can add almost 6 days to their hospital stay. And those are very costly days that they don't want to be in the hospital in the first place. So if you try to translate some of those statistics to what Saskatchewan does, and I hope these numbers are close to your own experience, but back in 2009, there was a patient experience survey in which patients believed that they had suffered a medical error. And roughly around 3.5% of patients thought that they had experienced a medical error while they're in the hospital. So for about 35,000 admissions a year in Saskatchewan, this equates to roughly 2,600 patients who believe they've had some kind of adverse medical event happen to them. If you use that journal article that I referenced earlier and apply those to your data, 7.5% of patient admissions experience one or more adverse events, 37% of those are highly preventable, and 0.66 of those, per the article, were actually died of a preventable event. If you do the math on those, you're killing about 14 patients a year in Saskatchewan. When I use those same data and apply those to my experience in my hospital, that's pretty darn close. We have roughly 22,000 patients a year at my hospital, and last year we, from my perspective, caused serious harm and death to at least 4 patients. And our mortality rate in our hospitals are only about 1.5%. So it may not seem like a big number, but if it's your loved one, it's huge. Just some comparisons. This is from the Health Statistical Information System. This is 2009 data again. Our life expectancy overall between the U.S. and Canada is pretty similar. Infant mortality, again, pretty similar. Male life expectancy, female life expectancy, pretty similar. The U.S., I'm ashamed to say, I think, is we spend 15.2% of our gross domestic product on health care. That's why it's not affordable in the U.S. We rank 1 in the world on how much we spend on health care. And if my counting was correct, you spend roughly 9.8% here in Canada, and you're ranking about 18 in the world on how much you spend. Does that resonate? Is that close to what you guys think too? Am I off on that? But that's how I understood the data that I looked at. So those are the quality challenges, and I don't know if you can read this or not, but this is our friend Einstein, who did all this complicated math, and he discovered actually that time is money. And if your physician's in a busy practice, you understand that time is money. I'm going to hopefully try to show you some ways to try to save some of your time and the time of your patients. So this is a cartoon that was drawn by one of my colleagues in primary care that tries to illustrate the swirl that goes on in a primary care office. If you're a family doc or an internist doing general medicine, you got all this stuff going on with your patients. You know, counseling, dealing with acute attacks of disease, chronic disease management, talking with families, filling out forms, care plans, the preventive care that's also a big part of this, time pressures, making diagnostic errors. I'm going to talk about diagnostic errors and cognitive errors in a bit too. I'll get to that in a second. I hope that's interesting to you. But anyway, this is just a depiction of the kind of demands on a primary care doc's time. And there's a journal article from the American Academy of Family Physicians back in June of 2005. Maybe some of you have read this one. That made some assumptions, but if you're a primary care doc and you have a panel of around 2,500 patients, and if you're trying to use existing evidence-based guidelines for the 10 most chronic diseases, it's going to cost you 10.6 hours a day of face-to-face time for that panel just to meet those guidelines for those patients. On top of that, you've got 4.6 hours a day of acute care. And so if you try to figure out if you've got enough time in a day for all this, it just doesn't work out. This is actually a typo. This shouldn't say 50%. This should say double this, because most of my colleagues think that underestimated the time it actually spends to do chronic disease management. So you could actually figure out that this is going to cost you 40 hours in a day to provide all this care. It just isn't possible unless you level load this, spread the load out, start using some of your staff in other ways at the top of their license, create teams to try to deliver this service. And Lean will help give you some of the tools to do that, maybe more efficiently than you could do it on your own. So again, back to saving time, less time wasted finding and correcting errors. That's the Japanese term for that is jidoka. And for those of you that are a little allergic to Japanese terms, I got to tell you, I was too, still am. My colleagues at Park, when we started with Lean, one of the biggest reactions was anytime you brought up a Japanese term in a conversation. But you can get past that. This is more about the tools and how you improve and not about the language so much. With Lean, you're going to spend less time looking for things. The term for that is 5S. So it's sorting out what you really need. 5S. I'm not going to remember all the pieces of that, but it's sorting it out, organizing your workplace, visual sweep for where things should be and if something's missing or not, simplifying so you haven't got a lot of stuff hanging around that you don't need, and then sustaining that so it's a continuous, clean, clear workplace. You know where things are at. You're going to spend less time reinventing the wheel for common problems and processes because you're going to create standard work around what people should be doing every day on their job. And I'll show you some examples of that with our standard rooming process. Less time wasted waiting. I imagine you all have waiting rooms. I imagine that they're probably pretty much full a lot of the time. And you got to ask the question, why do you have a waiting room in the first place? Wouldn't it be nice if a patient could just walk in, get their care, walk out, and you don't need a waiting room? You could use that real estate for something else. You should have, if we can accomplish some of these time savings, you'll spend less time responding to change situations and crisis management. And the idea here is to spend less time yakking about what's wrong with things and actually spend more time improving them. We use a term about taking advantage and letting people work to the top of their license. So if you have an RN, for example, in your clinic, are they working at the top of their license, or are they doing things that somebody else could be doing, clerical things, for example? So part of the work with Lean is to sorting out with standard work who should be doing what, and how long it actually takes them to do that type of work. Our reality is that things are pretty inefficient. There's a lot of rework. A lot of my colleagues are feeling burned out and just want to do something else or need to take a lot of time away. Anybody resonate with that? I hear some chuckles, so I must be hitting close to you. I think most people who are engaged in taking care of patients who have chronic illnesses pretty much know what the evidence is around what their disease management ought to be. But how do you provide that how much time it actually takes, we talked about earlier, that's a problem. From my perspective, care just is not safe enough. We hurt too many people unnecessarily, and we could do better with that. At least in our shop, patient satisfaction is low because of a lot of things that are dissatisfiers. Waiting is a big part of that. Having to redo things is a big part of that. And I suspect that there are some similar stories you can tell as well. And for us, costs are escalating. This is not sustainable in the U.S. The employers are going to quit paying for this as a benefit. Patients can't afford it. And Obamacare, I don't know. Don't ask me about Obamacare. I just don't understand it. It's huge. There's an election coming up. Is he going to be here after that? But I've heard some commentators say that Obamacare, well, one thing it may do, it may give us a chance to get everybody insured, which is similar to what you have here. But the other problem is how you manage the costs. And our difficulty in the U.S. at least is that some of the big businesses like pharmaceutical companies rather, folks who make medical equipment devices, and all the commercial insurance companies tend to have connections to the folks that make the laws. So who's your president? Does it matter? When these people are really pulling the strings, that's the only politics I'm going to get into today because that's way over my head. Okay, so lean. What does lean really require that we do? We need to see what we're doing. Making your workplace visual, seeing the workflows, that's a big part of this, seeing the waste, understanding the work. MUDA is the term for waste. We want to get rid of that. You don't know, you have no idea how much waste costs. And until you start eliminating it and seeing how your bottom line improves, it'll fascinate you. Teamwork is critical to this, particularly as I'll talk a little bit later about cognitive errors that human beings make, particularly physicians. And we need to be driving value-add activities, things that make a difference for our patients. The other part of lean is you never get done. You make an incremental change, you fix it, you re-standardize that work, and then you fix it again. And you just keep working and working and working to fix stuff because you're not going to run out of things to fix, I can tell you that. So our reality, and I suspect yours is, what exactly are we doing? With lean, remember I talked about time, and so a lot of our work trying to understand processes involves going around measuring things. And our staff first thought we were trying to measure them with a stopwatch and make them work faster. That's not the point. We need to understand how long it takes to actually do the work so we can figure out how to better manage the work and where the efficiencies might be or how we might separate the work to somebody else who can do something that doesn't need to be done by an RN or a physician, for example. What doesn't have to be done at all is, again, waste. So rework and things that you do that don't add value. Why are we doing it? What's the right sequence of work? I'll mention this a bit as we come back to what we did around managing our diabetes population with sequencing when you might do lab tests, for example. If you have it before the patient shows up, it's far better to talk about than it is if you send them off to the lab after you've seen them. And then you got to call them back with their results. Physical layout's critical too. Sometimes just the way we organize our workplace just isn't very efficient. It isn't very conducive to efficient operation. And so the principle here is what we need when we need it. That's one of the pillars of lean. So again, involving our staff with some of these questions and our patients, we put patients on a lot of our rapid process improvement workshop activities. So the RPIW workshop itself is a one-week activity where you actually go out and make change. And we'll put patients on those teams and look at this from their perspective, whether these changes we're making is going to add value from their perspective or not. We designed a cancer center with a 3P design process that involved patients. We redesigned our emergency center, again involving patients. They're very eager to help out, at least in our shop, and I suspect that's the case with you too. And then, as I mentioned earlier, you never get done. You go back and fix them again and again, and you keep making incremental improvements in what you're trying to fix. So again, getting started, just getting out and looking around, see what you can see. Go see for yourself. It's amazing if you go out and just watch what your staff does. Watch what your reception desk might do. Go down to your lab if you have a lab in your facility. Watch what the lab people do. And then when you start doing this, you start seeing this every place. I stand at line at Tim Hortons, and it just amazes me about the process that they use for serving their customers. And I got tired of waiting, so I went to a competitor. But standard work is another issue that Standard work means that you agree on a standard, and there's a standard process and sequence for doing something. And until you get everybody to adhere to standard work, you have no chance to improve it. If everybody does their own thing and there is no standard, what are you going to improve? So standard work is a big part of this too, along with time, so that you are all working to improve a standard work, re-standardize that work, retrain to it if you have to, and then move on. So when we say standard work, it's not a trivial matter, because until you get a standard, you don't know that means you can't improve anything. Seeing where people go, this is incredible. This is amazing. I'll show you a spaghetti chart in a little bit. Just watching where people go on their workflows. We did some projects in the OR early on, and just watching where scrub techs go and where nurses go to get a patient into a room, get the equipment, eat all this stuff. It's fascinating. A lot of waste, a lot of time moving things around. Look at this from the perspective of your patients. We talk a lot about value stream maps, which is basically the processes that are involved with doing something. And if you look at this from the patient's perspective through their eyes, you start to see where the waits and delays are. You start to address the causes of those waits and delays. Because the more you make improvements for your patient, the happier they are, and generally the happier you are too. Teammates. The value stream maps bring into play all the participants in the care of that patient as they go through your system or across your system. And you can figure out from that who plays a role in caring for those patients along with you. And then you start to understand how teams really function or don't, and how you can make those better. And then again, looking for the waste, critical for just keeping your eyes open. So I have 4 examples here from our own experience that I'll get into. And to this point, any questions that anybody has? Still with me? Okay. So we worked in primary care just on the rooming process and some of the things that went on around a patient care visit in primary care. I'll talk to you a bit about our diabetes initiative and trying to bring some focus and some standardization and some improvements on our care of diabetes patients. I'll show you one example about how to improve the care of patients presenting with acute MI, acute heart attacks. And then I'm going to tell you what, from my perspective, is the biggest value a lean can bring to an organization in trying to avoid harm to patients. So I'll talk about Jack's kidney. So this is a very busy slide. I don't need to have you memorize all this stuff. But there are several things. This is a summation of what's called a target summary report. And so for each of our RPRW projects, we'll have some key measures on there, like things like walking distance or real estate. Defects is another measure we'll have. This first one up here had to do with how many steps nurses took in 2 primary care clinics. And you probably can't see it there, but at this one clinic here, there were 22,000 steps a day that somebody took. They could knock that down by 14% at the end of their project. Another one here knocked it down by 65%. This is just reducing the waste and the workload on your staff, so they got more time to do meaningful things for you and your patient. This parts travel distance, we had a process where when you did a lab test on a patient, the lab would print a letter back to the patient, and then we would courier these lab letters back to the primary doc by van. And we were driving 65,000 miles a year moving paper around. You could think that's really stupid. Well, you're right, it is. But we figured out how to do this without having basically any travel time at all by printing these things, if you even need them, back in the physician's offices. We didn't have a way to do that until we started this project. Maybe you already do, but this is just an example of taking some waste out of the system. It's really kind of low-hanging fruit. This is though the same, attached to that letter transfer also was the time it took, and we took that from 240 hours a day actually, when you summed it all up, to something like 5 minutes or something. The capacity, this stuff down here, this all has to do again with defects in patient care. So we have a process in primary care that when a patient comes in, they get roomed. And what do you do when you room them? Well, you get their blood pressure, maybe your temperature if they got an illness of some sort. Their weight, typically. Look at their medication list. You get a correct list from the patients. That's part of the med-rec process. When we looked at this, the rooming process, we had something like an 89% defect rate in all those elements actually being done as part of the rooming process. And after our RPIW project, we knocked that down to maybe a 9% defect rate. Not perfect, but clearly an improvement. That's the other thing. You don't start out thinking you're getting 100% improvement in everything. Just get halfway there if you can. I mean, anything is better than what you've got usually. Setup time, we knocked that down. This is the amount of time it takes to change over a room from the time it's completed from the patient to the next patient. Knocked that time down by 67%. And then this last one was the nursing support to the room changeover time. Knocked that down by 10% or so. So just some examples of trying to create some simple efficiencies in a primary care office. It doesn't seem like a lot maybe to you, but when you talk again about 1 million patient visits a year in primary care, that's a lot of FTE, a lot of time, and a lot of cost that goes along with that. This is about our diabetes initiative. Back in, this was about 2000, I think 2004 or so, 2005. We had 9,000 known patients with diabetes in our system. Only 9% of those were considered optimally managed, and that means that their A1C was in control, again, blood pressure control, smoking cessation, lipid management. There's 5 elements of that. It was all or none when we measured this stuff. We thought this was pretty pitiful. In fact, we were one of the worst in Minnesota around this. So we started looking into this, and we created a way of doing external setup. So when these patients came in, their next visit was planned for them, including any lab work that was required prior to the next visit. We developed a registry out of our EMR, so we knew exactly which patients in our system needed care because they had diabetes, and we actually developed a person then, a role to manage and work that list so that if patients weren't coming in on their own, we'd contact them and bring them in. So we did 4 RPIWs over a 6-month period of time to establish at least some initial headway on trying to create a better visit planning process for appropriate labs that they might need. And then by working that registry, this population of diabetic patients were better managed. And our goal was to have fewer complications for patients with these diseases. Of course, that's not a short-term goal, it's a long-term goal. But this is how we sequenced it. We started out with the registry and a population manager to work that registry, creating standard work then with what's called next visit setup. And that was then identifying what those patients' care needs were going to be for the following visit. There was another RPW that came on in July, this was back in April, so July 2006, that created what's called extended lab menu. So each time the patient came in, the physician could actually designate on this lab what was required for the subsequent visit to ensure these were put in place, orders were written, and the patient would be scheduled for getting this done. Another component with this happened in September of that same year, where we developed standard work to identify the correct steps just in doing a blood pressure. When you actually watch somebody do a blood pressure, and if you do it by how it's supposed to be done, a lot of variation in that. So we had to standardize the method for doing blood pressures first of all, which seems like a simple thing, but until you do that, you have no consistent, accurate, reliable measure. And then a process for those patients who had elevated pressures at their first attempt to actually have it done with an automated machine that would do a sequence of pressures and average it to give you typically a better reading. It took more time, but at least that patient walked out of there with a better understanding, and the doc too, what their pressure actually was. And then a last RPIW in November we did just to try to roll all this work we just done and translate it to our Spanish-speaking population. So we weren't missing that population just because of a language barrier. By doing these things, our percent of optimally managed patients with diabetes increased just for this population increased 10%. And right now, by running this and continuing to improve on this, our percent of optimally managed patients with diabetes is up over 40%. Remember this, you have to hit all 5 of the elements to have it done, to get scored on this. And so there's a lot of belief that you can't get everybody with all 5 elements completed, but 42% is where we're at now, and it's one of the best in the state. This is another one that we worked on in the EC, Emergency Center, along with our cardiologists. And our goal here was to try to preserve myocardium. So the way you look at this is a chart that demonstrates the risk of death in hospital mortality with how long you've had your chest pain, and specifically how long it takes to get from the time you present to the ER to your balloon in the cath lab to blow up, to open up that artery. And the longer it takes, the higher your chance of in-hospital death. And this is just a sequence to show you, how much myocardium actually dies. 30 minutes, you got a little bit of endocardial death. 90 minutes, it's getting deeper, and by 4 to 6 hours, it's transmural, and that patient's not going to do as well. So if you think about this, and then this is our value stream for acute MI in a pictorial form. So patients develop their chest pain, and typically it's the macho guy who thinks this is indigestion, and so it's an hour and a half just sitting there taking Tums or something before they actually call 911, which is our emergency call. Ambulance shows up, brings him to the emergency center, gets admitted, gets initial triage evaluation, gets some initial labs, and out here now he's got ST elevation. It's acute MI. So what do? We mobilize our cath lab. That takes 20 minutes. There's a quick H&P that's done, and they get to the cath lab and get prepped and get this opened up. The actual procedure takes about 15 minutes. So all this time is going by, and if you think back to that previous diagram, more and more myocardium is dying, and the risk of death is going up. So our first approach to this, let me go back to that a second. So just keep this in your mind. This whole process from start to finish was about 190 minutes. The door to cath lab time was about 100 minutes because you take off 90 for the time he was spending, just worrying about his chest pain. So one approach to this, and we got help from our emergency medicine services, our ambulance people in the community. We thought, okay, it takes 20 minutes to mobilize the cath lab. What if we could do this test en route while this is just waiting time, basically? And if we can do this EKG en route and show this ST elevation, we can save 15 minutes off of this cath lab time, because this was part of the 15-minute evaluation when they first came in, which only leaves you, so we can start mobilizing the cath lab back here in parallel to the rest of the stuff going on, and now you've only got 5 minutes of cath lab mobilization time, basically remaining by the time the patient gets there, which knocks this down by 15 minutes in total. And depending on where you were on that curve early on, it may actually save a fair amount of myocardium and how much risk of mortality you might have had. So let's say you presented right about here, and your door to cath lab time, if we could knock 15 minutes off, we might put your risk all the way back to here in terms of death. This is just one approach, one single improvement method that we tried early on and were successful with. Other things built on top of that to try to get your door to cath lab time. We're down around 30 minutes, 35 minutes now for most of these patients, which is huge. So here's my sad story. This is a CT scan you probably all recognize, and this is the patient's left kidney. This is a post-op exam, and that's his bad kidney. We took out Jack's good kidney, and as many of you have been doing, we worked for weeks and months, and it seems like forever, in our ORs to ensure that the patients were scheduled and consented properly. We identified them correctly when they came to the OR. We marked the site when it was laterality involved. We do the timeout before the incision is made. We did all that stuff with Jack, and we did it all correctly. The problem was we made an error in Jack's care 3 months earlier. Jack is not a very healthy guy, and he'd actually been having blood in his urine for about a year off and on, and had a diagnosis made several months earlier that he had a left transitional cell carcinoma of the calyx of one of his left kidney. Before we could operate on Jack and take his kidney out, we had to fix his heart because he had very bad heart disease. He underwent a 5-vessel coronary bypass surgery, had a real rocky course in the ICU, all the complications you could probably expect from an 85-year-old guy having this done, but he survived it. After a recovery time, he went back to his urologist and said, I'm now ready to have my kidney tumor addressed. And the urologist who had been seeing him all along saw this patient in the middle of a very busy morning. If you look at the schedule during that time, there were a lot of patients with right-sided complaints like kidney stones and renal cysts and things of that nature. The urologist, as many physicians do, delayed dictating that exam till the end of the day. And so in dictating this exam, he, in his mind, translated left to right, and all of a sudden now Jack has a diagnosis in the chart of a right kidney cancer. The tumor's on the left side, the CT shows it's on the left side. Up until this time, the chart has said left side, now it's right side. Nobody caught it. Jack was scheduled for a right nephrectomy based on that chart note. He was consented for a right nephrectomy. Now you can ask, how come Jack didn't know the difference? Because surely he knew that he had left side before. Jack's a very trusting guy. In fact, he has kids in healthcare. They believe that what the doc says must be true. Nobody ever challenged it. Or he didn't remember. He could have been sick enough not to remember too. We don't know for sure. So he gets scheduled, gets consented for this, goes to see his cardiac surgeon who says, yep, you're ready to go, get your right kidney out. He goes to his primary doc who's seen him for years to get him cleared for surgery. Primary doc says, yep, you're good to go, Jack. So Jack comes in, and the urologist and a colleague preoperatively are looking at Jack's CT scan, looking at the approach. Jack had previously a AAA bypass repair, aneurysm repair. They were worried about getting in, how are we going to get to this kidney? There's going to be scar tissue, what's the approach? They're looking at the CT scan actually and looking at the wrong side, looking at the approach. Nobody looked at the radiology report, which would have said left kidney tumor. So this whole thing proceeds. Nobody caught it. We had several opportunities to catch this thing, but because of a clinician error early on in a dictation that nobody else caught, we operated on the wrong side of Jack, took out his good kidney, and this is his post-op film. This was pretty much the end of this surgeon's career. He does office-based practice right now, and that's about it. Jack went on to die of his kidney cancer. We actually sent him to Mayo, and they went in with a laser through a nephrostomy tube and tried to laser this thing, to preserve kidney function, but the thing reoccurred further down the urinary tract in his bladder, and he died. The reason I'm bringing this to you is because there are some lean tools that we can use to throw at this and try to prevent these things from happening. What we're dealing with here has become an interest of mine, and it's all about how we think. So this particular case demonstrates a number of cognitive biases that we're all subject to. One of which is diagnostic momentum. Once we hang that diagnosis of right kidney cancer on Jack, no matter what the chart said, or no matter what the CT said, that diagnosis stuck and nobody challenged it. Confirmation bias, do people know what that is? It's when you have a hypothesis about a diagnosis and you do certain tests to try to confirm your diagnosis, and you accept those tests that confirm your diagnosis, and you sort of ignore those things that don't really fit. So even though if you could look back in the chart that Jack's had his CT scan early on that said left-sided tumor, everything else we just rejected that and just went with the stuff that's in the chart that said right side, like physician notes. So be careful of confirmation bias. Availability, this is what happened, I think, to the urologist that particular day. He was seeing a lot of right-sided stuff that particular morning, and so everything became right side in his head, and Jack got translated as right side instead of left side. So what you've been seeing ends up being what's available to you to make a diagnosis with. This happens, this happened to me when I was in practice. I'd see kids during flu season, and everything with a cough and a fever and stuff is the flu. Well, some of these kids actually have something else. They have RSV or they have pneumonia, something else. So what you want to avoid is confirmation bias and this thing called search satisfying. So did anybody ever have your parents tell you that you always find something in the last place you look? Well, you quit looking, right? Well, that doesn't work in medicine. If you're a radiologist and you see that big pneumonia that the chest x-ray was done for, but you miss that little nodule down here that's actually a cancer, you're search satisfied up here, but you miss this because you quit too soon. We all do this. It's human nature, particularly physicians who are used to looking at things in patterns. So be careful about search satisfying and confirmation bias. Anchoring happened to this patient as well. Once we labeled that Jack as a right kidney cancer, his other treating physicians just anchored to that. But it's very similar to diagnostic momentum. I don't think gender bias played a role on Jack so much, but that's another one that comes into play. I'll give you another example how this played out in another case. We had a 75-year-old woman, a nurse actually, who presented to her primary doc, who has seen her for 20 years, with right-sided abdominal pain and fatty food intolerances. And of course, she got an ultrasound, right? Ultrasound shows what? Gallbladder, right? So, yep, you got a gallbladder we got to take out. Well, before she had a chance to call this patient with the gallbladder study results, the patient had another attack, and so she presented to the emergency room with her abdominal pain. The ER physician pulled up her radiology report that showed this gallbladder with sludge in it and said, yep, you need to have your gallbladder out. So we hooked her up with a surgeon who took her to the OR the next day, and the surgeon gets in there and she hasn't got a gallbladder. We took it out 10 years earlier as part of a procedure to take out part of her bowel. It was an incidental cholecystectomy. That same surgeon had done that case. But he didn't look back at the chart 10 years earlier to see her entire surgical history. The gallbladder ultrasound showed probably a loop of duodenum that the radiologist, given the information, mistook for gallbladder. And so you got availability, you got search satisfying, you got confirmation bias. All these things came together in that particular patient to go in and do a phantom gallbladder operation. Now, I will tell you that the patient didn't have any pain afterwards, and I can't explain that, but we shouldn't have done the procedure. And but I think there's a little gender bias there, is my point. When I did my training many years ago, the old adage was fair, fat, fertile, and 40. It's gallbladder if you got abdominal pain. It seemed to fit this person, but we should have looked further. I put this here again because I didn't want you to think I was going to end with this one up here. So, search satisfying there twice. Okay. So, what's my point in all this? This kidney case, I think we could. Here's how we went about trying to keep this from happening again. We use some of the mistake-proofing tools that you will learn with Lean. You can talk about metacognition as a counter to cognitive biases. You know what metacognition is? Thinking about what you're thinking about. Okay, who's got time for that? So I don't think that's a very realistic one, but it does bring up the point about our obligation to self-inspect our own work. There's a lot of discipline involved with that. It takes time. It takes some integrity in terms of your honesty. So metacognition may be an approach to dealing with cognitive biases, but it's not a very fail-safe one. I like this concept of skill-based, knowledge-based, and rule-based behaviors. Some of you probably are far more averse at this than I am, but I think of this in this way. Skill-based behaviors are things like driving a car. There are certain things you need to do skill-wise to drive a car. Turn the key, run the brake, run the gear shift, turn the steering wheel. Those are skills. You can develop those and do them automatically without thinking about them. Rule-based behaviors apply when you're driving your car because you obey traffic signs, you drive on the right, at least in our countries. You yield to pedestrians. Those are rules that you have to adhere to when you're driving a car. Those also can become so automated in your head you stop thinking about them. It allows you to use your brain for higher functioning while you're doing these things. So most of us will drive to work every day using skill-based and rule-based behaviors on automatic pilot. Now today it's a little slick out there, so you may have to start paying a little bit more attention to your driving. Or the other day they were tearing up the streets in my neighborhood, so I had to take a different route to work. Now I got to think about that. So now I'm using knowledge-based behaviors. These are things physicians use to get themselves out of trouble, to try to figure out what's going on when a patient doesn't fit a pattern. So you draw on your training, you draw on your experience. These are all knowledge-based type of behaviors. Trying to be aware of where you are in this as you're dealing with patients is a little tricky. A lot of us get back into this skill and rule-based behavior because things sort of fit a pattern. And when things fit a pattern, we tend to go back on some of these cognitive biases and we stop thinking about whether I'm missing something. Am I search satisfying? Am I not adhering to or paying attention to lab tests that are a little bit off what I expected? And do I just ignore those? So confirmation biases. So if you can think a bit about where you are in terms of your behaviors in dealing with a patient, you can start to avoid and apply more of your knowledge and skill and experience to those patients, and that'll keep you out of trouble some of the time. It's kind of like listening to your gut too. I don't know about you, but if my gut's telling me something, I better pay attention to it. But the way we approach some of this stuff in healthcare is with secondary inspection. Somebody else inspecting my work. If it's not accurate, they either fix it for me or they send it back to me to fix. There are some hierarchy issues, of course, with this in medicine. Physicians tend to be held on a pedestal by a lot of people. They don't, if you're dealing with a team, they're afraid to speak up in the OR, for example, or they're afraid to speak up in your primary care office because they think you know what's going on. So we need to develop a culture, from my perspective, where people not only are free to speak up if they're part of your team, but they are obligated to speak up. That's how we keep people out of trouble. You know what this term is? Who's covering your six? Any mariners out there or pilots? So if you're on a boat or in an airplane, straight ahead is 12 o'clock and 90 degrees this way is 3 o'clock and 6 o'clock is directly behind you. So the concept here is with your team, who's watching your tail? Who's watching your backside? Nobody's watching the surgeon's backside on this cognitive error that he made about Jack's kidney. Which gets me back to the true meaning of team. It's not just the folks that you're working with that you bring in and off and on to care for a patient, but it's the obligations of the team to be part of that team, to speak up, to be engaged, to be working with their knowledge-based behaviors as much as possible. So I'm starting to preach here, and I don't really want to do that, but that's how we approached Jack. And so what we did, and I'll show you some specific examples here, but we created a rapid process improvement team to look at the entire value stream of Jack. So Jack comes in with blood in his urine, what happens? We mapped this whole thing out, and we figured out where along that value stream there were opportunities to have caught this mistake. And so one place that we could catch this was when the surgeon went to schedule this procedure, he said, schedule on a piece of paper, he wrote down right nephrectomy for kidney cancer. Okay, so when the scheduler got that piece, what we said now going forward was that surgeon's nurse is also going to find a secondary piece of information apart from his saying so that confirms the correct laterality. So she pulled up the RAD report that had the kidney CT scan on there and brought that together with the scheduling to confirm that when we should have said left nephrectomy, that's what was said on the CT scan as well. Since it wouldn't have matched in this case, there would have been a stop the line right then and there. It goes back to the surgeon to review the RAD report, his own dictation, and to clarify which side are we really talking about. That was the first step to trap this at the scheduling process. We try to do this now for every case involving laterality. Another trap, it's identical, is when the patient presents to the OR for the procedure itself. We pull up again the consent that we have, what was scheduled, and a confirming bit of information. Typically it's another X-ray report, could be a pathology report, but that's got to match with what the surgeon says that they want to do. If not, we stop and sort it out. So that's the value of the value stream map, was try to map this stuff all out and find those places in that value stream that we could actually error-proof this, or at least create traps where this wasn't going to happen. So I'll show you examples of all these concepts along the way, and we'll get through the rest of this. And again, any interruptions, feel free to let me ask questions. So this is a value stream. This is very complicated. I mean, it looks complicated. This is actually a value stream about medical subspecialties. So this might have been cardiology, for example, or neurology, one of these. But it just basically shows where patients come from, what the various steps in this whole process are to see their physician, to do lab, whatever it might be. And we measure all these times, how long it takes to do this, what's the time here in terms of delays and waits. That's what's on the bottom line down here is the actual time for the process step that adds value, the time for the waiting that doesn't add any value typically. These yellow things here we called Shazams are basically identified opportunities for improvement, either in the care process itself or in getting rid of a wait or a delay, something like that. But this is the methodology we start with, creating a value stream and then identifying our opportunities for improvement along the way in the value stream. Once we've done that and we've picked a part of that value stream to go after, we'll do what's called a spaghetti diagram. So this is just an example of where people go. I'm not sure I can read where that actually happened. Oh, this is this is a tech in the endoscopy suite where they go to clean a scope. So it's back and forth doing this, and then this is just to do one scope. So it gives you a picture of all the travel time, in this case wasted motion, basically, for this tech to be doing this work. When you map this out, you also get an idea of the steps in that person's process. And so what you do then is you start to time the steps of the process. You do cycle times on each step of the process, including the time it takes to move from one step to the other. And there again, you can start to identify places where you might be able to identify some waste to get rid of, or some delays, or some places to add value. I mentioned earlier the value of this type of methodology in terms of process improvement, quality improvement, because it always has a beat to it. It's not just how long it takes to do something, but what your demand is for services, which is your tack time. So there's always a rhythm to these things. So for example, for the case of the OR, what we can do is look at what's called tack time, which is the time available versus your demand. And we can't control this usually. I mean, let's say you have 30 patients a day in your primary care offices who need to see you, and you have 8 hours in a day to see those patients. When you do the math, that's your tack time. When you start to measure some of those things, how long it actually takes to see that patient, to do their rooming, to write their orders, to whatever else you do in that visit, those are cycle times. And these things, by and large, should add value to that patient's experience. The lead time is actually the total time it takes for a particular process, from any arbitrary beginning to any arbitrary endpoint. So, and that's all the value-added stuff, along with the waits and delays. So if we go back, for example, to this, lead time would be the actual time from entry point to completion. That's your total lead time. Cycle time is for this part of the process, this part of the process, this part of the process. Get the idea? And then you can start to use some formulas to actually calculate how many people you need to do the work. And I'll show you a simple example of that with cardiology in a second. But if you understand what your tack time is, which you have no control over, and you measure cycle times, if you take your cycle time and divide it by your tack time, that's going to give you roughly how many folks you're going to need to do the work. There are some other calculations regarding lead time that tells you how many patients, for example, you need to keep your process moving. If you get too many, it's going to stall. If you don't get enough, it's going to stall. So the tools start to help you manage those work processes more efficiently and identify how many folks you actually need to do the work. If you think you're overburdened, do some of these measurements and figure it out. And more than likely, you'll find out that you really are. What do you do then? Well, you start the load level. This is one of my cardiology colleagues who did. He's actually an ultrasonographer. So he likes to look at cardiac echoes. I couldn't tell you what this is, but what he's looking at here is peaks and valleys, both on the echo but as well as on the EKG. He's making the point that if we can work at a constant pace if it's predictable, but it's the peaks and valleys of demand that stress us, whether it's too many patients to deal with or I'm sitting around wasting time, one or the other. So this is a story about Bud. Bud's one of our interventional cardiologists. And Bud says he only has 2 speeds, and one is slower than what we're watching him at here. But when we measure this actual time it takes for Bud to do a cath and open up an artery, it's pretty constant. It takes Bud about 15 minutes to do that. So we know that for Bud, and his colleagues are all pretty much similar. And so if you go back to Bud and remember the tack time, which is the demand divided by the time available. If you have one cardiac, this is very simplified because there are other things involved. I'll give you that with taking care of a patient with acute MI. But if you take, let's say you have one cardiac patient every 15 minutes and Bud takes 15 minutes to do his part of the procedure, he can keep up, right? So you could figure out, let's suppose all of a sudden your demand goes up and your tack time now goes down because your demand went up, and you got a patient every 5 minutes and it takes Bud 15 minutes, what are you going to do? Well, if you do the math, 15 divided by 5, it takes you 3 cardiologists to keep up with that demand now. Very simplistic example, but using the tools, even in a more complicated fashion, you can actually figure out how many, based on what your tack time is, how many folks you need to do the work, whether it's doing open arteries or whether it's doing primary care office work or doing an operation. So that's how these tools come into play. These are just examples of standard work from a primary care office. So we created this form, and there are various things on here that must be done, including a legible order. So handwriting. We've now gone to EMR, by the way, so all this stuff has become part of a computer system and not on paper any longer. We had 4 clinical service lines: inpatient, surgical services, primary care, and medical specialties. Each of those was managed with a dyad, a VP and a physician. Underneath those, except for my service line, we had medical specialties or medical departments, or various specialties, with a department chair who would report to the chief. And that's how our organization worked, but you can imagine patients would see us across those service lines. So part of the value of having these dyads was working both from a clinical perspective as well as an operational perspective to ensure our handoffs and our transition of patients across these service lines was as seamless as possible. It's not perfect, I'll give you that, but some of these lean tools actually help you with some of that management across service lines and silos as well. I was in one of the first waves for training, the first wave for training, along with all of my physician chief colleagues and a few department chairs. And so it took a little bit of courage, I'll tell you offhand. Most of us were a little bit skeptical about it. We just had, within the past year before we went to Lean, some training in Six Sigma. So all of a sudden now we've gone from PDSA, which we were doing with IHI, to Six Sigma, to Lean, and it kind of felt like the flavor of the day. This one stuck. We still use these tools now 10 years later. But it took a little bit of courage on the part of the clinicians. We got a lot of flack from some of our colleagues about what we were really doing here and was this the right way to go. But as we got more and more engagement with physicians in this and brought them into these improvement projects, it helped to pave the way. One of our first projects to sort of bring physicians on board was endoscopy. We had an endoscopy suite through which we could put about 33 patients a day, doing both colons and upper GIs and an occasional bronch. And our GI docs were saying, we're maxed out. Our waiting list for colons is 6 months long. We need more facility, more docs. We went into that endoscopy suite with about 3 RPIWs in sequence. And at the end of that time, we were putting 65 patients through that a day without adding staff, without adding more physicians, just by standard work, sequencing things properly, and feathering in the different types of procedures. And if you actually spend the time to measure what it takes to do a colon versus an upper GI, you could figure out how you could feather these things in a rational fashion and get more completed in a day's time. We worked our colonoscopy list down over about 6 or 8 months, and we don't have a waiting list any longer. Although I'll give you, we've now, since that time, this is several years ago, we've doubled the size of our department and built them a new endoscopy suite anyway. But the point was, early on, we could double their productivity, and since they were all happy, because we doubled their productivity without adding any space and any additional time to them. So getting some early wins like that helped to bring people on board. I think one of the advantages that we had that I suspect you don't is that we employ essentially all the physicians that work in our hospital. We have a few independents, especially orthopedic surgeons, that still come in, but most of our physicians are employed. And so when you start talking about physician dyads with your leadership teams, it was easy for us. It's probably more difficult, I would suspect, for you given the kind of a system that you have to deal with. But I think you can work around that and figure out how to make that work. It really helps to bring your clinicians on board if you can pair them with your operational leadership. You have to be committed to this. This isn't a one-time thing and you're done. We've trained, I think, 8 or 10 waves of people now that include clinicians. And the training goes on as we bring on new people. So you don't ever finish this, and you'll never finish making process improvements. We had some opinion leaders along the way that were very negative about this, and you're going to have them. And frankly, I think they're a blessing, because the conflict that develops when you start to have debates about these things and some professional arguments about this actually makes you stronger. And very few of these folks that were early on very negative about this, very few of these folks remain negative. And there were a few that left, I'll give you that. It just wasn't a good fit for them. It's going to happen. But we've sustained this now, and this is our way of continuing to improve our organization and trying to improve our work for our patients. Having people who can speak to this eloquently helps a lot, but I'd be careful about how eloquently they speak. That doesn't seem to be rehearsed or programmed. It's got to be, from the heart, and so it helps to have those kind of folks on board as well. For me, this was a no-brainer as the champion for quality and safety. I mean, to me, this is the way for making care for our patients as safe as we could make it, and producing the highest outcomes for these patients as well. So that's kind of what it took, and it's different every place you go. There aren't many big organizations in the U.S. like Park Nicollet. You have Mayo, you have Virginia Mason, maybe a few others. But I think you can, if you understand sort of what the tools are, and can bring some physicians on board with this in terms of what the benefit is not only to themselves and their practices, but their patients as well, it becomes easier the more you get involved with this, my perspective. So again, this is about trying to eliminate waits and delays for patients as well as for yourself. So I don't know if you ever had a nurse that walked out to your waiting area and just asked your patients if they were really sick enough to waste your doctor's time or not, but that's something you don't want to ask patients. So this probably isn't the right perspective. This is just a graphic about people waiting in line. I walked past our lab the other day. Early in the morning, they're always very busy with fasting labs to draw, and so you got people waiting in line. It still happens, but the better you get at this, the better you deal with the peaks and valleys like the morning crush. But we just don't want to be wasting people's time or their money or making bad decisions that jeopardize their health care. And with Lean, it's not going to be perfect, but it's going to help you get better. See the things that aren't perfect so you can work on those, and we'll be better off for it. So that's about all I really have to say. I'd really like to hear some questions and see what's on your mind.
Questions from the floor? Dr. Kettle.
Thank you, Dr. Schmidt. Actually, I'm coming here on behalf of Deputy Dan. He had to step out of the room. I'm at his table. And he just asked that I maybe just offer a correction on one of the statistics you provided about potentially preventable deaths from error in Saskatchewan.
Yeah.
If you actually extrapolate the Baker-Norton study, to our population, we would probably have somewhere between 400 to 700 preventable deaths from error per year. And he just mentioned it in the ministry, even if you lowball it, the conventional assumption is that we probably kill about one patient per day from errors in the system.
I appreciate you saying that, and let me just go back to that, because just to show people what you're talking about. The extrapolation was then from this study, 1 in every 13 patients experienced an adverse outcome, of those highly preventable. So what you're talking about is this math right here, this 0.66%. Now I went back to the study, and I used to have that number you have in here, and this may be my misunderstanding with the study, but I understood the study to be talking about applying this percentage after you've knocked it down by this 37%. I looked at that study a couple of times, and this is how I understand it, but I have seen the number you're talking about, which does make more sense if you go back to this first number right here. So I have a suspicion that this number that I came up with is actually my misunderstanding of this study as it relates to that particular number, and I appreciate you bringing that up.
Yeah, and I guess the other thing Max just mentioned, we need to remind ourselves, of course, the Baker-Norton study just dealt with hospital care.
Right.
And deaths occur in community care.
Absolutely.
So the burden of harm is much higher than that in real life. So
absolutely, well taken. I appreciate you saying that.
Well, thank you. It was a great talk. As physicians, we look at evidence, and say, for instance, if I had changed to give randomized or spinal background, I had to look at data, I had to look at randomized control trials before I really change myself. I think what you're doing is you're showing us that change works. But what we really want is local data. How many diabetics are there in my community? How many of them progress to blindness? How many of them progress to end-stage renal disease? How many of them get amputated? And so once we get that data, I think you'll see us forming teams ourselves to prevent progression of that. So I'm not seeing that at this moment. I'm seeing a whole bunch of other, this is what happened in Alaska, and this is what happened in the mountain, or really in Regina. what we need is facts, numbers, and so that we can work it out for ourselves.
I appreciate that. Relative to the ability to tightly control patients with diabetes to reduce long-term complications, some of you may know that we have what's called International Diabetes Centers attached to Park, and they've been caring for diabetes patients now for probably 30-some years and teaching people around the world how to take better care of patients. And their studies have clearly shown that the tighter your control is, the fewer eye complications, the fewer kidney complications, the fewer vascular complications. So the extrapolation between that work and the work I showed you about trying to manage these patients more efficiently and with tighter controls, I think makes the case for us at least that these patients will have better outcomes down the road. I don't know that my diabetic patients are different than yours. I expect that they really aren't. But your point's well taken. It's nice to have your own data to work from. That's also true of these process improvement activities. I mean, a lot of this measurement is pretty crude, but it's good enough for making improvements on. Then you standardize it and you keep tracking this out over time and you audit this stuff and be sure that your changes actually stick. And a lot of the flack I've had, flack if you want to use that term, from my own colleagues has been, your data is not statistically valid. It's measurement for improvement, not measurement for rigorous publication. That's true. It's a different kind of data set. And I'm okay with that.
I have a couple of observations. One is following up Dr. Prasad's observation and having visited your facility in Intermountain. The basic premises is none of us get out of bed in the morning to provide a bad care for our patients. And everybody wants to do the best care for our patients, but we think that we do is good. That's the premises we start off with. And at the end of the day, we think we have provided good care. But the problem is, we don't have a systematic way of tracking of what are the events that's occurring in the data collections, data presentation, when there is a long wait of patients who are waiting to see us, or to provide who needs the expertise of the group, which are healthcare provider is. It creates the problem of pausing to think about it, is the collection of data, synthesis of data that makes sense for the clinicians is the problem, and also for the system. And also the cost associated with it is also we don't do a good job at all. We have no way of knowing what the cost of anything that we do at any given point in time. We can know it in a gross manner, but if I want to look at it individually, I have no idea what that is. If I know, then I have the obligation to professionally, ethically, to provide the best standard of care that's evidence-based. And when we don't have the data, and also then we have the ability to provide the standard of care that we need to provide. And then we can work backwards.
I appreciate it. We'll take one last question before our lunch break. Thank you.
Hi, Cheryl Bowen, and this is more of a comment than a question. Prior to coming here, I was at Penn State where we had a HRSA grant to develop patient-centered medical home curriculum for the medical students. You may be aware that we visited Colorado and Kaiser. We didn't come to Park Nicollet. I'd like to offer to the group the curriculum because I think our students need to learn team-based care. I think we have a long ways to go before we're able to implement these things, but I'm willing to. I have the curriculum with me and I'm willing to share. Thank you.
Thank you.
Thanks. I totally agree with you. I think that the training for team-based care needs to start probably back in kindergarten. But for sure in our medical schools, nursing schools, respiratory therapy schools, we should be teaching us as teams, my perspective, and not as individual silos. I totally agree with you.
Thank you very much, Tom. That was a great presentation. Just one comment and really a challenge to the floor. Some of these principles are really easy to start putting into practice in your own office. Little steps, okay. The previous speaker just said that we have a long way to go before we can start implementing these. I already implemented several of them in my office with great success. And so I think that we mustn't think that we've got to do the whole thing or nothing. You can start by doing little things at the office that are consistent with lead principles, and you can see the tangible benefit right away from day one.
Right on, man. You know, the longest unit starts with the first step.
Through the bank.